Hello everyone, a very warm welcome to all of you. I'm Dr. Muskan Alawat representing Voice of Healthcare and today's session is proudly supported by BSV. We are here for an important clinical dialogue on practical strategies across the continuum of prostate cancer management. It's my pleasure to welcome all our distinguished panelists for the evening. We have Dr. Ashwin Mallya, Senior Consultant Urology and Uro-Oncology from Sri Gangaram Hospital, Delhi. Dr. Fahad Afzal, Visiting Consultant, Medical Oncology, Jaslok Hospital, Mumbai. Dr. Pinaki Mahato, Director and Senior Consultant, Medical and Pediatric Oncology, HCG Center Care, Vadodara. We are honored to have with us our moderator for the session, Dr. Sujoy Gupta, Senior Consultant, Uro-Oncology, Tata Medical Center, Kolkata. With that, I would like to hand over the session to our moderator, Dr. Sujoy, to take over the lead, sir.
Good evening, Dr. Mallya, Dr. Afzal, and Dr. Mahato. We haven't met, but I am Sujoy. I work at Tata Medical Center in Calcutta. Now, without wasting too much time, we'll dive deep into the topic today. I think the focus of the topic is very clinical, practical oriented. In our real life scenario that you experts and eminent personalities in the field practice on a day-to-day basis. So if I go to the first focus area today, and the discussion will be with Dr. Mallya, who is the senior consultant in urology and uro-oncology. Firstly, I'll focus towards the organ-confined prostate cancer. What would be your systematic approach? The PsA kinetics that you look at, clinical examination, whether you depend on targeted or systematic biopsies, and the role of multiparametric MRI in the detection of organ-confined disease. If you enumerate your approach to organ-confined disease, please.
Thank you, Dr. Sujoy. We haven't met, being in the same community, although I think you have recently joined Tata Memorial. I'm not aware. I haven't met you so far. Probably we'll meet sometime in the future. So thank you, Voice of Healthcare and BSV for the invitation. So, sir, first of all, when we talk about organ-confined prostate cancer, this is a very important thing for us in terms of how the patient's prognosis is going to be over the next few years. So, first of all, when a patient comes to us with an elevated PsA, we definitely take a detailed history because a PsA has to be always judged with the clinical context. As we know, sometimes PsA, a single reading of PsA elevated, we may not consider. But if the PsA, we have at least 2 readings and a clinical examination is suspicious, then definitely we go ahead for a MRI of the prostate, a multiparametric MRI. Then depending on the findings of a multiparametric MRI, we then go ahead and do a biopsy if there is a PIRATS 3, 4, or 5 lesion on the multiparametric MRI. So my approach is transrectal ultrasound guided biopsy, which is generally fusion biopsy if the need arises, or at least a cognitive fusion, wherein we sit with the radiologist and figure out where exactly the lesions are so that we can target those lesions. In addition to those lesions which are seen on the MRI, we also do a systematic biopsy because even we have found in our own research that taking only targeted biopsies may miss around 10 to 20% of clinically significant lesions. Following this, if it turns out to be positive, then depending on whether the patient has intermediate or high risk prostate cancer, we subject the patient to a PSMA PET CT scan, which definitely tells us that whether the disease is organ confined, that is, it's confined to the prostate, or whether there is some local advancement, as in seminal vesicle is involved, or local lymph nodes are involved, or there is systemic spread. So for me, this is the sequence of events to diagnose organ confined prostate cancer. And you got my thoughts about the biopsy as well.
Okay, thank you very much. It's very clear and systematic approach. Now, would you put more reliance on the MRI for local staging, or is PSMA PET your focus area for local staging?
Definitely a good question, Dr. Sujoy, because there is some recent push towards PSMA PET scan. As you know, PSMA PET CT is very widely available. So we as uro-oncologists, when we said a patient has come with an elevated PSA and he has already got a PSMA PET CT scan from the word go from elsewhere. So my approach, as I told you, PSMA PET CT is a later stage investigation in my practice. My workhorse for prostate cancer is MRI, a multiparametric MRI, which gives me a lot of information. And of course, the radiologists have to be very well trained because they have to be very well attuned to the PIRATS version 2, and they have to sit with the clinician and figure out which all lesions are there. And so that is about I rely mostly on the MRI for the local staging, but for systemic staging, definitely I'd rely on a PSMA PET CT. Coming to another aspect that you brought about in your first question was about the PSA kinetics. So when do I depend on PSA kinetics or PSA density? So PSA kinetics basically means how much the PSA is jumping from year to year or from a certain time period to another time period. So if this is generally, we get a clue. If there is a person, say a person in his 50s who has a PSA of around, say, 3, and he comes again next year with a PSA of 4, and then he comes again after 3 months with a PSA of 4.3, which basically means that there is a definite PSA velocity of around more than 0.75 per year. And the other thing that we depend on is something called PSA density. So there might be a patient with a PSA of 6 and who has a 120 gram prostate. So even the prostate size can explain the PSA elevation. So PSA, I just want to tell the audience, is prostate specific antigen. It is not prostate cancer specific. Many times prostatitis or just a large
Right.
prostate, they can have elevated PSA. So these are the two aspects that I wanted to touch upon. I hope I have been able to answer your queries.
Yes, yes, yes. I think you've more than answered all the aspects. Now, we see a lot of patients in the PSA range between 4 and 10. Do you still use the free to total ratio in determining who may have a significant prostate problem?
Yeah, this is, you hit the nail on the head because this is a very commonly seen situation. So when we see gray zone PSA, like a PSA between 4 and 10, we depend on multiple things to kind of lead us towards a diagnosis. One of them is free to total ratio. So the theory is that when there is a prostate malignancy, the free PSA percentage comes down. So where does it start becoming suspicious? So the theory says that even 25% onwards, the suspicion begins. But when it hits 15% of the total, when the free PSA is 15% of the total, that is when we have to think that there could be a significant lesion inside and we may have to do a biopsy. Now, again, with the advent of very good multiparametric MRI, a lot of these things can be taken with a pinch of salt. But in my clinical practice, I utilize free total ratio quite a lot because it helps me make decisions for patients. And with a combination of MRI, free total ratio, PSA density, PSA velocity. So all these things help me in that gray zone PSA, which is between 4 and 10, to make a decision whether I should go in for a biopsy or not.
Thank you very much. I think what you essentially allude to is there are multiple factors which you take into account before you decide to go and do a biopsy. The other, quickly, one point that you mentioned, if it's intermediate risk group or high risk group, then you arrange for a PSMA PET. So in the low risk group, what do you use?
So in the low risk group, even till say a couple of years back, okay, I was very much dependent only on a bone scan. Okay, I'm sure. I think Dr. Sujoy has worked in the NHS and probably come to India. So investigations have, where in Western systems where investigations have to be rationed, you cannot use every investigation for every patient. So for low risk prostate cancer, the chance of finding a metastatic lesion is very low. So there are health systems where a metastatic workup would just be a, probably a CT of the chest and a MRI of the spine or something like that. But in India, because of the availability and the cost of PSMA PET CT has come down, that is why even in low risk people are, going towards a PSMA PET CT. But in my practice, I would probably be happy even with the bone scan, and that should suffice for me because in low risk prostate cancer.
Yeah, I think you will agree that we see patients as tertiary referral centers where patients actually appear in your clinic with a PSMA PET in hand. Sometimes even
Absolutely.
before a diagnosis of prostate cancer has been made, more recently. And with
Yes.
regards to availability, India is way ahead with regards to availability of all these investigation modalities. As you mentioned, in the NHS, you have to go through a protocol to be able to get a PSMA PET. Here, you go to most places, they will gladly do a PSMA PET for you. So that's the different kind of practice we have here. Thank you very much. That's a very good, clear, methodical approach to localized prostate cancer. The other point I would like to allude to is we have seen quite a lot of um, information with regards to screening for prostate cancer. And most of the data has come from the Western world. The largest trial, I think, is the European randomized study, European screening for prostate cancer. Now, where do you see screening for prostate cancer, the relevance of screening for prostate cancer in India? Would you rather target your PSA for a particular group, or would you advise screening above a particular age in the Indian scenario? And how practical is that?
So, Dr. Sujoy, I think, see, population screening as a strategy, I think, has been given up in most of the Western world. I basically would like to draw attention to uh, the PLCO trial and the American Task Force for screening, okay, which gave up population screening because they felt that the benefits of the risks of screening and outweighed the benefits, because that was at a time when prostate surgery and prostate radiation probably had a lot of morbidity. And but more recently we have made great advancements in the field of prostate cancer treatment, especially organ confined as well as metastatic. We would come to that in the later with the later speakers. One thing, in India, population screening is going to be a very, very expensive affair if we are going to do it for every single male over the age of say 55 or 60. I think that strategy is not going to meet with success. What I feel is more practical in India is opportunistic screening. People who present to the hospital with lower urinary tract symptoms, I think they form a good population in which screening can be done, provided they are in the age group of probably, I would say, from the age of 55 to 70. Uh, Before 55, I think it would be overkill unless they have some very strong family history of at least one or two first degree relatives having prostate cancer, that too at a younger age. And over the age of 70, if they are having an expected life expectancy of more than 10 years, I would still advise to go in for a PSA. But if they have a lot of comorbidities, probably not. So in my practice, or even in general advice, if somebody asks me, I would say between the ages of 55 to 70 is the sweet spot where we can advise screening for PSA, and that is the population that is generally getting PSA done in India as well.
Okay, excellent. Thank you. I think it's very logical that we target our PSA checks to people who have got symptoms, and we essentially call it opportunistic screening. I think that is the area which is practicable also. Uh, Thank you very much. That's
Thanks.
Dr. Mallya's section done now. So we
Thank you.
move on to the next topic. Uh, the focus area is systemic therapy optimization, and we would request Dr. Fahad Afzal to enlighten us about the systemic therapy that you use. There are three situations where they have discussed. One is in the area of early metastatic disease. The second is high risk localized cancer, and third is biochemical recurrence. So essentially, we need to know what is your approach for systemic therapy in these situations, and how would you choose your therapy? So, systemic therapy selection.
Good evening, sir. Thank you for. I would like to thank BSc for giving me this opportunity and especially such a relevant question. So, basically, optimizing systemic therapy across the prostate cancer continuum, it demands a very integrated, patient centric, and a evidence driven strategy. So, in 2025, our decision making has become more complex. This has been primarily because of the advanced the molecular diagnostics that now we have access to, PSMA PET staging, and of course the expanding therapeutic armamentarium. But our most important goal while optimizing the sequencing strategy is to align the intensity of the therapy with the individual risk while preserving the long-term quality of life and keeping the future therapeutic options open. So the three situations that you mentioned, the first being the biochemical recurrence. So in biochemical recurrence, the management hinges on distinguishing an indolent relapse from an early systemic disease, and that's where the PSA kinetics plays a very important role, particularly the doubling time. So patients who have slow PSA kinetics and a negative imaging, PSMA PET imaging, can often be managed with observation alone. In these patients, premature initiation of ADT, androgen deprivation therapy, may compromise the quality of life without actually improving survival. At the same time, in patients who have a high risk biochemical recurrence and those who have a PSMA PET lesion, in these cases, we can adopt a multi modality approach, one of which is intermittent or continuous ADT. There are some data which shows that addition of certain androgen receptor target therapy in these patients along with ADT will improve those, especially those who have a fast or a rapid biochemical progression. In patients who have oligometastatic lesions on PET, which are asymptomatic, they can be managed with even local therapies like radiation and like SBRT, etc. And this may help us delay systemic therapy escalation. And this shows how it is important to integrate the local and the systemic strategy together. When we talk about the early metastatic hormone sensitive prostate cancer, treatment intensification at the outset is now has always been the standard of care. Multiple phase 3 trials have shown that adding an AR inhibitor like abiraterone or apalutamide or enzalutamide to ADT significantly improves the overall survival. In a high volume disease and the patient is fit, a triplet therapy can be opted for, which includes ADT with an AR targeted agent and chemotherapy, that is docetaxel, and that has shown to have a benefit. The choice between a doublet versus a triplet depends on the balance between the disease burden, the patient's fitness, comorbidities, and how, if the patient has already been started on chemotherapy, then how they have tolerated the chemotherapy. And along with these factors, the genomic profiling, we have access to comprehensive genomic profiling now. So This also helps us influence the decision of whether to add chemotherapy or any other drugs for that matter. So, for example, a patient with a deleterious HRR mutation like BRCA2 may actually be candidates for earlier addition and incorporation of PARP inhibitors in such cases. Coming to the third situation of a high risk, a localized or a locally advanced prostate cancer, here systemic therapy primarily helps enhance the curative local therapy. So long-term ADT combined with radiation therapy has shown to have good response rates. The challenge is how we can integrate two modalities of therapy without adding up to the toxicity. So in all, the sequence strategy depends heavily on multiple factors, and we should not think of it as a rigid algorithm where AR inhibitors are being used in sequence, which promotes cross resistance. Rather, uh, incorporating different agents with different mechanisms of action in a well sequenced manner will help improve the outcomes of our patient. And it's a dynamic process which is guided by the patient's response, the PsA, the toxicity, and several other factors. I hope I've been able to answer that question.
Yes, it is a big area, but you have summarized it very well. Just one or two points of clarification. In your practice, as you say, the practice of management of metastatic prostate cancer, there have been several changes over the years, and as new molecules come up, a little bit of a change happens, new data arrives. About a few years back, ADT with docetaxel was the standard of care. But in your practice, when you mention triplet therapy, are you still having a significant number of patients on triplet therapy, or are you choosing ADT plus abiraterone or enzalutamide now, and less of chemotherapy?
So I wouldn't say less of chemotherapy, but yes, I confess that triplet. There are very handful number of patients who are eligible for triplet therapy, because as I said, these patients have to be fit. They should be able to withstand the toxicity of the triplet approach. So the number of patients who are eligible for triplet therapy are not as much in my practice. But chemotherapy, yes, for patients who have a high tumor burden, I still use chemotherapy in combination with ADT. And yes, most of the patients, a major proportion of the patients are on ADT with androgen receptor inhibitors.
Okay, thank you. We go into the second part of your area. Now, leuprolide generally has been one of the mainstays of androgen deprivation therapy for quite a long time. But long-term androgen deprivation therapy comes with a lot of side effects. We know there are metabolic and endocrine side effects. When you start these patients on ADT or leuprolide, what are the areas that you look for? How would you follow them up to prevent these adverse metabolic and endocrine toxicities? Uh, how do you manage these patients?
Thank you, sir. Uh, as rightly said, ADT, especially leuprolide, is central to the prostate cancer management. So, knowing and managing the systemic side effects, the toxicities, especially the metabolic toxicities, the endocrine toxicity, it requires a proper structured approach. So in my practice, we follow a very protocolized framework which involves three parts: a baseline risk assessment before starting the ADT, early detection and routine surveillance where we monitor for toxicities while on ADT, and a prophylaxis to ensure that the chances of developing these toxicities are less. And that is, of course, coordinated with the other disciplines also, with my endocrinologist colleagues, orthopedic colleagues, etc. So the baseline evaluation begins with a comprehensive assessment to identify if there's any cardiovascular, metabolic, any skeletal risk factors. We do a detailed medical history focusing on presence of comorbidities like diabetes, hypertension, whether the patient smokes, has any prior cardiovascular disease. Then comes the baseline biochemical parameters like liver functions, renal functions, etc. A baseline, a weight, BMI, waist circumference, and all that. A bone health evaluation, typically with a DEXA scan, in all men who are, especially in those where I'm who are expected to receive a prolonged ADT therapy. So once this and a cardio-oncologist, at times we have access to cardiologists who have special interest in oncology. We involved these specialists prior to initiation so that it is easy for us to follow up, especially in patients who have pre-existing heart ailment. Once the patient is on ADT, again we employ a very structured 3 to 6 monthly monitoring surveillance, which involves weight, BMI, checking for any weight loss, muscle loss, sarcopenias, sexual dysfunction, etc. And then comes the prophylactic strategies that we have. In prophylactics, we counsel these patients if they are if they have been smokers or they are still active smokers, on strategies on how they should they can stop smoking. If they're vitamin D deficient or calcium deficient, then supplementing that as and when required. Proactive anti-resorptive therapies like bisphosphonates or denosumab for especially for those who are at high fracture risk. For cardiac optimization involving the cardiologist, keeping a very tight control on the cholesterol and the lipids. The sugar should be under control. Blood pressure as per the recognized guidelines for the same. Management of the hot flashes, the mood disturbances that accompanies in the first initial phase of androgen deprivation therapy. So managing these toxicities is a very important part of androgen deprivation therapy, and it begins from the first injection or the tablet, and it goes on for years together. It's not just limited to the first few months. So it's part of the survivorship program. So, and at the same time, it involves multidisciplinary strategy, and it's focusing on the cardiac, the metabolic, the endocrine part, etc.
Yeah. Okay. Thank you very much. A few clarifications here. You are managing all these patients with advanced prostate cancer and who've been on ADT for a long time. Do you see a lot of cognitive decline in these patients plus depression?
Yes, sir. Depression, yes. Unfortunately, I confess we don't do a formal cognitive assessment with scoring and all. But yes, mood disorders are seen in patients on ADT. If it goes to a point where it affects his social life, we also involve our psychiatric colleagues for managing these symptoms. Cognitive decline is seen in patients who are elderly on ADT because the pre-existing Alzheimer's adds up to the cognitive dysfunction that ADT can be associated with.
Okay, thank you. The other thing with regards to the bone health, your patients would go on to vitamin D supplementation and calcium right from the start, or would you hold them back and use them as required basis?
So checking the calcium and the vitamin D levels are part of the baseline assessment. And if these patients are deficient prior to starting ADT, then supplementation is begun before initiating the therapy. And in patients who are severely deficient, we ensure that there is timely assessment of the deficiencies to ensure that it has been corrected.
Okay. Now, with regards to this use of bisphosphonates, do you have a preference whether you'd like bisphosphonates or denosumab? And if so, why?
So, efficacy wise, there is no one better than the other. It's can always be debated. For patients who have renal dysfunction or who are at risk of having renal dysfunction in the future, I prefer the more kidney safe denosumab. If, of course, we are not discussing finances, but if finances are not an issue, for most of our patients, I still rely on bisphosphonates, zoledronic being the bisphosphonate of choice. A dental, uh, prior to starting therapy with either bisphosphonate or denosumab, dental clearance is part of our guidelines, our institutional protocol, and we ensure that patients who are at risk of ONJ are not started on medicines. But uh, if accessibility is not a problem, then I prefer denosumab over zoledronic.
Okay. Now, you mentioned a cardiovascular assessment right at the start. So, do you frequently change your option to antagonists if you
Yes.
think that there is any cardiac issue?
Yes. So we are all aware that LHRH agonists have a transient testosterone surge, and they carry a slightly higher risk of cardiovascular events, especially in men who have a pre-existing heart disease. In these patients, LHRH antagonists like Degarelix, or now we have access to Relugolix, there is a rapid suppression without flare, and that has a more favorable cardiovascular profile, especially in patients who had prior coronary artery disease, a prior MI, or a heart failure. So there, I prefer LHRH antagonists over the agonists.
This has intrigued me quite a lot because all the systematic reviews, etc., point to lower cardiovascular side effects with antagonists. But have you in your practice seen a lot of cardiac events with LHRH analogs? Or is
Not
it
a
more of
lot.
like a
Yeah.
statistical sort of data that comes out?
So definitely not a lot, but the patients who have encountered cardiovascular issues were the ones who were on the depot preparations, the 3 monthly LHRH agonist preparations, and having a cardiac event has prompted me to switch over to a antagonist in these cases. But yes, it the incidence of events with LHRH agonist have, in practice, are not as often as it's otherwise reported in literature.
Okay, thank you very much, Dr. Afzal. It gives us a clear idea about your approach and how you manage, and it's very easy for people like me to understand. mm, that it's very logical and clear, and very in quite a detailed approach, really. The next area for discussion is with Dr. Mahato, who's the director and senior consultant at HCG Center, Vadodara. Good evening, Dr. Mahato.
Good evening, sir.
Hi. Hi. I think the area that we expect your expert opinion is treatment escalation in prostate cancer, mainly in hormone sensitive metastatic um, prostate disease. What triggers your decision to escalate therapy? But I accept that the question is a bit peculiar because now the approach is already escalated from start. So, if you give us some idea about biochemical progression, radiological evaluation, or clinical symptoms, and the escalation approach that you take in your
Yeah.
practice.
So I think it is a very interesting question, and I agree with the previous speakers that the treatment of prostate cancer is much more nuanced than other malignancies. We have to use our common sense. We have to look at our patients very closely to decide. Now, as the previous speaker already discussed, that we decide what to do, whether we want to give chemotherapy and ADT on day one, considering the volume of the disease, or we just want to go with the abiraterone plus ADT. Having said that, patients over a period of time are going to progress. So if a patient is on abiraterone plus ADT for a long time and then has a increase in the PsA, or there is clinical deterioration, or you have some radiological progression at some site where you feel that this patient is going to have a problem down the line, like impending spinal cord compression or a fracture. So in those patients, yes, definitely going for a localized therapy or escalating by switching to chemotherapy is what we generally do. Having said that, these patients are more often exceptions than the usual, because most of our patients would have some clinical symptoms before we actually need to switch the therapy. Many times it has happened that we have PSA elevations, but the patients are absolutely asymptomatic. And we understand that this is not going to be a curable setting. So sometimes we do continue the same treatment if the velocity, if the PSA kinetics is not very high. And we would observe those patients and wait, still they become symptomatic before we actually switch them to chemotherapy. Also, the problem is that giving ADT and abiraterone or enzalutamide for a long time is very easy and generally associated with a good quality of life. But giving chemotherapy indefinitely, especially in the castration resist setting, is generally not very feasible. Generally, we have to take a decision as to how many cycles of chemotherapy we can give, because most of our patients would not tolerate chemotherapy beyond 10 to 12 cycles. And there we have to maybe take a call and go back to the hormonal therapy.
Okay, excellent. You mentioned that the patient may be clinically well, although there may be PSA progression. We see the reverse also, don't we? That the PSA remains okay. But in your practice, while following these patients up, would you do cross-sectional imaging in the absence of clinical symptoms or absence of PSA rise?
So most of our patients, if they are asymptomatic and the PSA stays within a particular range, I do not regularly do the imaging. Having said that, if a patient the PSA is normal and you are feeling that the patient is having more of the clinical symptoms, it is possible that they might have a neuroendocrine differentiation. In which case, one has to do a PET-CT or a CT scan, because again, with now more of our patients being on these therapies for a long time, we are seeing more patients now with neuroendocrine differentiation, and which is extremely aggressive disease to treat, difficult disease to treat. So that is something that I think should not be missed.
Okay, excellent. Now, in your practice, if you mentioned that if the patient has been on abiraterone for quite a while, if there is PSA progression, would you consider converting them to enzalutamide if they have been on therapy for more than a year, say, and if
So
there is
again, I
PSA?
think Yeah. So again, I think it's an excellent question. So the general logic is that if you have kept the patient on a hormonal therapy for a long time and the patient has progression, generally we try to switch them to chemotherapy, because the belief is that if you have hormone resistant cell lines now accumulating, probably chemotherapy is going to work better. And once the chemotherapy you have given us a particular course of chemotherapy, probably they again become hormone sensitive and you can switch them back to hormone therapy. Having said that, there would be certain patients who would not be very keen to go for chemotherapy. They have a very, very indolent kind of disease. The sites that are involved are non-visceral. The volume of disease is still quite low, where I think it is very, very practical to switch them to enzalutamide from abiraterone.
Okay. Now, because you treat these cancers on a regular basis, are you using the newer drugs, the apalutamide and the darolutamide, yet in your practice for metastatic hormone-sensitive prostate cancer at the outset?
Yeah, so I think I have used apalutamide in few of my patients. Unfortunately, what has happened, because we have used the older drugs for quite some time, we try to use these drugs when other drugs have failed. And unfortunately, in that setting, I have not really seen any responses. If you look at the meta-analysis or the network meta-analysis that they have done between all the drugs, that is enzalutamide, apalutamide, darolutamide, what essentially comes out is that probably these drugs can achieve a quicker PSA decline, a more durable PSA decline. But if we compare the overall survival benefit that comes across from these three drugs, we really are hard pressed to choose one drug over the other. So that is why probably in the proper clinical trial setting in which that drug was used is the right time to use. We know darolutamide is a very, very expensive drug by Indian standards. The other drugs are very cheap. That is why most of us would be hard pressed to use darolutamide, especially if the patient is not financially affordable. So most of my experience has been with enzalutamide and to some extent apalutamide, but I don't think I've not seen that thing that apalutamide is working for a longer time or is giving better response as compared to enzalutamide. So I think more we need to collect our real world evidence, use it more in the frontline settings where probably the benefit is going to come out.
Yeah, I think it's extremely important in the Indian scenario about cost of therapy, because these patients will be on long-term therapy with various agents and cost comes into play. And darolutamide, I believe, is pretty expensive at present. And we'll have to wait for the cost to also come down for making it uh, more user-friendly that way. Now, we go into the last area, Dr. Mahato. Uh, with more and more hospitals, oncology units coming up, And there is a push towards a multidisciplinary approach to cancer care, and particularly in prostate cancer, particularly because there are so many aspects to managing these, the treatment, the side effects, managing the side effects, managing the complications, interpreting, histology, change of histology, radiological assessment. How do you see the role of multidisciplinary team meetings and multidisciplinary care pathways in the management of advanced prostate cancer?
I think it's an excellent question, and as I already said, that prostate cancer requires multimodality management. So a discussion when the disease is diagnosed, and also a discussion at every progression of the disease is very important, because we know that as medical oncologists, we are not going to be the only persons treating this disease in the long run. We definitely need the help of our surgical radiation colleagues as well as the other specialists that are inquired. So I think there is a very keen and an increasing role of having an MDT discussion at every point of progression in the prostate cancer. And I think all of us can contribute. Also, what I think has not been covered till far is, I think, the role of genetics as well. So we had the previous speakers talking about genetics. So we should be looking at that aspect as well, because now we have such drugs available in our day-to-day practice, which we can use in such patients. So I think more and the treatment scenario is going to become more and more complicated as our patients live longer and longer. And that's why it is very important to have the MDT discussion at every point.
Excellent. Thank you very much. It's very important. We have a very strong MDT in our hospital, and it helps us manage the patients better, and ultimately the patients benefit by this multidisciplinary approach. This brings us to the end of our discussion. Thank you very much for your time, and thank you, BSV, for organizing this discussion. We went through the whole spectrum, but it's a very short period of time to be able to cover everything. But I think you've touched upon all most practical aspects of management, the day-to-day things that you see, and day-to-day, strategies that you employ. Thank you very much. I'll pass you over to Dr. Alawat, whether she wants to say a few words before we conclude the session.
Thank you, sir.
Thank you.
Thank you.
Thank you very much.
Rahul, are you there?
Sir, Dr. Alawat is not here. You have to in the session.
Okay.
Yeah.
Shall we conclude the meeting then? We've had a very good discussion. And thanks personally to Dr. Mallya, Dr. Afzal, and Dr. Mahato.
Thank you, sir. Thank you.
Thank you. Thank you, Dr. Sujoy, for moderating this wonderfully. Thank you very much.
Thank you very much.
Thank you.